Good evening, everyone. Dr. Michael Twyman. Tonight we're going to be talking about statins and muscle intolerance. This is a topic that I know I've been asked a lot about, and I hear it all day in my office. So this is not a video about pro or con. Should you be taking a statin? That's a conversation best to be had with your own physician or healthcare provider, or if you see me, chat with me in the office. But there's going to be more chat about muscle intolerance and statins. That's the number one side effect that people notice with these medications that cause them to not be able to take them long term. So statins are tools. Anything that you put in your body, risk benefit, why you're putting that medication, supplement, food in your body in the first place. So up to 25 million people are taking statin medications. You can know if you're on it if it has the word statin at the end of it. So simvastatin, lovastatin, rosuvastatin, pravastatin, lovastatin. Those are kind of the generic names, but you may have also heard them called Zocor, Lipitor, Crestor, Pravachol. Those are the most common ones. Livalo is a newer one, but there's no real generic on that yet, so not a lot of people are on that one. Statins were initially discovered in 1971, and again, like I said, they're a tool. But statin intolerance, not uncommon. It's variable on the number of people who are reported to have it. In most of the trials, they're going to say it's like 1% to 2%, but in my clinical practice and in most people's, it's much higher. There's reports up to 5% to 20% of patients have some issue that necessitates them either cutting down on the dose or switching the class of the medication. What's the difference between a myalgia and a myopathy? So myalgia is muscle pain, myopathy is muscle weakness. So, people will frequently describe, they feel a weakness, tenderness, cramping, may even have like a flu-like symptoms where your body just aches. I've seen some patients have more kind of a tendon issue, and they think it's actually their joints where, that they think the medication is causing that. But it's probably more affecting the tendons around the joint that gives them that symptom. People who tend to have more issues with it tend to be women, people who are, quote, elderly. That's debatable what that age is. I've seen it as low as 50 and as high as 80 years old to consider somebody in the elderly class. And then people with kidney disease or with liver disease tend to get more issues with medications. So, how do statins work? Well, they're known as an HMG-CoA reductase inhibitor. They basically limit cholesterol production in the liver. And by doing that, then the body has to do something known as upregulating the LDL receptor. Because the liver's not putting out as much cholesterol, the liver needs its own supply of cholesterol, so it puts out this little catcher's mitt and will clear the cholesterol particles from the bloodstream and bring it back into the liver. But where the statin works is about upstream 30 steps before cholesterol is produced. And there's things downstream from where that enzyme is working that your body also needs. And many people have heard of coenzyme Q10, sometimes known as ubiquinol or ubiquinone. That's something that is present in your mitochondria. The mitochondria are the location that do many things, but one of them is they make energy for your cells. And CoQ10 acts as an electron shuttle and an antioxidant inside the mitochondria, so it prevents you from rusting, but it's helping energy move through the system. Without CoQ10, energy doesn't get made as efficiently. And this is one reason why people may have this muscle intolerance is because they're depleting CoQ10. The muscles don't have the ability to make as much energy as they need, and the pain or the weakness develops. The data is a little bit mixed on coenzyme Q10 supplementation, reducing that risk. In my practice, I do fairly liberally recommend coenzyme Q10 supplementation, but the trials are a little bit mixed. Maybe it's just the dose or the design of the trials weren't done long enough, but typically, if patients have I would say, strong indication to be on a statin, I'm usually going to recommend that they consider supplementing CoQ10 and check blood levels to make sure the levels have been optimized with it. The kind of most feared side effect of statin therapies in muscles would be something known as rhabdomyolysis, where the muscle is actually getting broken down from necrosis or dying. I can honestly say in my clinical experience, I've never seen a case of that due to a statin. There are case reports of this. When I was in the military, I took care of a lot of Marine recruits. They got rhabdomyolysis from overtraining often. So in 100-degree weather in South Carolina, they got dehydrated and they had muscle breakdown. You would know if you have rhabdomyolysis because, again, someone feels like you have the really bad flu, but your urine will be very dark, Coca-Cola-like. Or you look like you're peeing blood. That's not actually blood, but that's myoglobin. So that's muscle proteins getting spilled out into your kidneys, and it can basically plug up the kidney tubules and lead to kidney failure. So you have to hydrate those people very aggressively. But again, extremely rare that would be caused by a statin, unless you have something else going on. You're on an immunosuppressant, you're on an HIV medication, or something else that really would jack up the levels or the potency of the statin. There are people that won't tolerate certain classes of statins. Doesn't mean that they're quote allergic to all of them. Tends to be atorvastatin, which is Lipitor, or Simvastatin, which is Zocor, that tend to cause most of the muscle issues. So if you've been on those ones with muscle issues, you just talk to your doctors and see can they switch you to something else. Typically, pravastatin is the one that tends to cause the least amount of muscle pains, and it's not as potent, so it tends not to lower your LDL count as much. But sometimes you're using the statins for other reasons other than lowering the lipids. You're using it for inflammation, improving endothelial function. So sometimes if you haven't tolerated one statin, you can switch up to another one. Typically, if you're having a lot of myalgias or muscle pains with the statins, you stop the medication. Symptoms should go away within 2 weeks or less, and then sometimes you re-challenge to see is it truly due to the medication. If the symptoms come back on with that medication, then that one is not the right one for you. You talk to your doctor and see is there something different that they can switch up to. Sometimes you can get away with dosing every other day, especially with the longer acting ones like rosuvastatin. Sometimes once a week or twice a week. Twice a week generally, rarely once a week, but sometimes you can still get a benefit doing that. And then some people really just aren't going to tolerate multiple statins. They try 2 or 3, and they're not a good candidate. Why are these people not good candidates to continue? There's a couple of reasons, and we'll go into that. But there are non-statin alternatives, and it'll depend on what your vascular risk is to determine should you be using some of the other big guns like the PCSK9 inhibitors, or the injectable medications. Those are known as Praluent and Repatha. Those are a couple $1,000s a year, and usually mostly indicate for people who have what's known as familial hyperlipidemia, or they just crank out a ton of particles because they have a defective gene in their liver with that LDL receptor. For the most part, they don't clear it from the bloodstream. Your body just keeps pumping around these particles like little cars on the highway. More likely they're going to interact with the arteries, and you're going to develop plaque with that. And there's also a newer medication on the market called Nexletol. It actually works upstream from where the statins work, and it does not deplete CoQ10, and it also does not get into the muscle cells. It only works in the liver cells. So there's no chance to get muscle pains with that medication. I have a few patients on it who previously couldn't tolerate multiple statins, and they're tending to do well on this, and it's lowering the metrics I'm looking at about as well as the statins that they used to be on. But if you see me in the office, I do a fairly comprehensive blood work panel. It's going to be 7 to 8 pages long. But if people come in and they're talking about that they have issues with their muscles when they're on these type of medications, that the top reasons that they tend to have issues, one, they're vitamin D deficient. So you have a vitamin D level of 10, you're almost always going to have muscle pains with it. You can have muscle pains with just low vitamin D to begin with, but if you put a statin on top of low vitamin D, almost guaranteed. So I want you out in the sun, getting your vitamin D levels up. How high? If you're not supplementing, I'd like to see your vitamin D levels 50 to 60. If you're supplementing, and this is not individual medical advice, once you're over 30, I rarely recommend that you continue the vitamin D supplement. I already kind of talked a little bit about CoQ10. Dose is going to depend on your blood levels. But typically, the trials show maybe even up to 600 to 800 milligrams is needed to potentially decrease the muscle symptoms while you're on a statin. Also, not uncommonly, if you have hypothyroidism or underactive thyroid, you're going to have more muscle aches and pains. And then getting into a little bit more of the genetic markers. So 2 common ones that I will check in the office is ApoE. You get 1 copy from your mom, 1 from your dad. So you either get a 2, a 3, or a 4. You get 1 copy of each. So you can be a 2-2, a 2-3, a 3-3, a 3-4, or a 4-4. The patients who have an ApoE gene, that is like number 4, they tend not to tolerate the potent or the highest doses of the statins. They get more of the muscle aches and pains when they're on those high doses. Does not mean that they cannot take them, but they probably need to use a lower potency one, or it would be more like a water-soluble one, like pravastatin or rosuvastatin. The other common gene that I will check for patients who've been on more than one statin and had muscle symptoms, there's a gene called SLCL1B1 that determines essentially how well you metabolize the statins. So in some people, this is not exact science, but it's like, if you put 20 milligrams in them and they had an SLCL1B gene, it's like putting 200 milligrams in that person. So it just sticks around a lot longer. They tend to have more symptoms with it. And that's a fairly easy gene test to get with most of the major cardiovascular lab companies. So that's what I want to share with you tonight, is that statins, are a tool. This is not a pro or con statin conversation tonight. It's just that, the number one reason people can't tolerate statins long term is some type of muscle intolerance. We talked about what those tend to be and the symptoms that you have, and some options you can do to help really reduce those symptoms. If you're seeing me in the office, we'll have this conversation. But I will definitely be putting some information in the notes section of this when I put it up on my page. So I want to thank you guys for joining tonight, and I'll open it up to questions. We're waiting for the questions to come in. I'll share a couple updates for Apollo Cardiology. So my main physical practice is in St. Louis. There's some big news coming soon. We're going to be upgrading some very interesting mitochondrial repair options are being available with our new space. And I'll have a little bit more information coming soon on that. I will be doing another health event, health retreat down in Cancun in November. The dates are going to be pretty firm on November 18th to the 21st. The details will be forthcoming. Most likely this is going to be at the JW Marriott Hotel in Cancun. Been there a couple times. Outstanding place to learn about light water magnetism, how to really make your mitochondria work well. So somebody say they wish I was moving to Utah. I've been to Utah once. I went to Red Mountain. It was awesome. Loved hiking there. But have a lot of family, friends, and patients in St. Louis. I'm always going to have a base here, but I do work with patients all over the United States. So if you have a doctor locally there who can do some of the stuff, I can act as a kind of educational consultant and put people on the right path. So if you're interested in that type of telemedicine consult, just shoot me a direct message after this. Or you can come to my website. It's drtwyman.com, just spelled like it is at the top of the screen, drtwyman.com. So is everybody enjoying their summer solstice, the longest day of sunlight this year? They'll probably go outside for the next 2 hours after this to soak up a little more red light tonight. Let's see. So I think next week's topic, we'll likely go back to a mitochondrial-based one. I'll probably break it down into different sections. We'll talk a little bit more about light next week, how light actually interacts with your mitochondria. It's absolutely fascinating. And if you want to learn a good book in the next week, that'd be Health and Light by John Ott, OTT. There's a very detailed textbook. I always mess up the way I say it, but I think it's Light Shaping or Light Sculpting Life, Roland Van Wyck. It's a very detailed history of how light actually affects biology. It's going back through 100 years of prior studies and data A lot of it's out of Europe and Russia, and because of the Cold War, a lot of that information was not necessarily shared with the West. So it's very, very interesting the way that your mitochondria make energy, but how your cells communicate with light, and that's how life really works. All right, so somebody's asking, can you develop myalgias from Lipitor, which is also known as atorvastatin, after being on for many years without issue? Yes. Typically it's going to occur when somebody first starts medication within a couple weeks, or they've increased the dose. But it can be one of those things where, as you're depleting CoQ10 or you're depleting vitamin K1, which I should say it has an effect on the way vitamin K2 is produced, might have an effect on muscle sensations. So it is possible, and definitely atorvastatin or Lipitor is more common. So I can just tell, and this is just a side note, my personal experience, I rarely recommend people be on atorvastatin because of the risk of the myalgias. So if patients come in seeing me in the office and they're on it and they're tolerating it, I will leave them on it. I'm not necessarily going to automatically change them, but I don't start people, especially women, on atorvastatin or Lipitor because they tend to have much more of the issues with the muscle pains. Questions about words on easy water, cholesterol, sulfate deficiency, and cardiovascular disease. I don't know exactly how they're linked per se, but the easy water is exclusion zone water for those that don't know the shorthand on that. Great book by Gerald Pollack on that, the fourth phase of water. So when light, especially red and infrared light, hits water, it separates into positive and negative charges. So you're essentially making a battery in the water with that. You do need your cholesterol to be sulfated to be able to essentially have it work appropriately. And so sunlight on your skin will be converting a form of cholesterol ultimately into vitamin D. Then that's go to your liver and kidney, get processed to be active. So that has something to do with it. But yes, if you have low vitamin D and low easy water, you're going to have low energy, and you're more likely to get cardiovascular disease. So somebody's saying it's a slightly unrelated question. They saw an ad for red light therapy, morning yoga. I assume you wouldn't want to combine red light therapy with yoga, but yoga with red lights would be beneficial. It sort of depends on what exactly they're wanting to do with the red light. If you precondition the muscles with red or infrared light before you start stretching such, you are sort of charging up the muscle cells, the mitochondria in the muscle cells. So maybe you're not going to be as sore after doing a round of yoga. But otherwise, yes, I would not be opposed to having a room with red light on and people doing yoga. It won't affect their melanopsin receptors and cause a lot of inflammation. So yes, ideally everything exercise should be outside. So outside is what you evolved under. Yoga outside would be outstanding, but if you're inside, I personally would have a red light panel on. Currently, see some light reflecting off me. I have the windows open. So just sitting behind glasses can filter out UV light, and it's going to filter out a good portion of the red spectrum. So a lot of the blue light's still getting through the glass. So it's not as bad as sitting directly in front of a phone or a computer screen, but you're still going to get a lot of blue light just sitting behind glass. And so if you exercise in that type of environment, that causes a different reactive oxygen species to be made in your mitochondria. Different signals get made with the different light environments that you're under. So optimally, you exercise outside so your body knows what to do with that light signal. So for those joining, thank you. So tonight we just went through statins. It's not pro or con should you be taking them, but if your doctor is recommending that you take a statin and you're concerned about your muscle health or you've had a side effect while on those statins, tonight's talk went through what the symptoms people can expect, what you could potentially do to lower the risk of getting the muscle pains, how to get blood tests that will tell you are you more likely to develop muscle pains. depression, low vitamin D levels, hypothyroidism, underactive thyroid, or if you have a gene issue with an ApoE4 gene or an SLCL1B1 gene, you're more likely to have issues with statins. Women in particular, I don't like using the word elderly, but because I saw different ages, but anything over 50, and some studies over 80, are definitely more likely to get muscle pains on statins. And then people who have kidney disease or liver disease will also more likely have issues, just as a baseline. So, see if any other questions come in, I'll answer them, but otherwise I'll let you guys go tonight. As always, this is going to be saved on my Instagram page. I'll have a little more of a descriptors with some facts and ways to ask your doctors for the correct labs, to know if you're at risk of getting muscle pains while you're on statins, if you've been recommended to be on a statin. And then next week I'll be talking about how light interacts with your mitochondria. All right, guys. Well, have a great week. It's the summer solstice, longest day of sunlight in this hemisphere. So get outside, soak up some red light, and we'll see you guys next week, Monday, 6 o'clock Central Time.